Hi all, you're very welcome back to this afternoon's session. My name's Derek Cribbett, I'm the nurse lead with the Critical Care Programme. Delighted next to be able to introduce Dr. Ganesh Suntharalingam, OBE, who was President of the United Kingdom Intensive Care Society during the first year of the pandemic and remains the co-chair of the National Emergency Critical Care Committee, a voluntary multi-agency collaborative set up by the Intensive Care Society. He's the clinical lead for critical care at Northwick Park and Ealing Hospitals in London. And the former became the first UK hospital to declare a COVID critical incident in March 2020. Unfortunately, Nicky Credland, the chair of the British Association of Critical Care Nurses, is unable to join him due to unforeseen circumstances, but delighted that Miss Julie Highfield, a clinical psychologist in critical care in Cardiff, has agreed to discuss with Dr. Ganesh the UK's experience of COVID over the last 2 years. Many thanks.
Thank you very much. It's a real honour to be here, particularly to follow that powerful patient story just then. And as mentioned, I'm joined Nicky Credland to join us, particularly given the comments earlier today, which I've seen on Twitter about the centrality of critical care nursing. So she was here from the BACCN. My organisation and Julie's, the ICS, also represents the multidisciplinary team, but I'm sorry, you're primarily a doctor speaking to begin with. And a special thanks to Dr. Highfield, who's joining us. So she works with the ICS as our wellbeing project lead, and she's a clinical psychologist at Cardiff, and I think was the first in the country to have a dual staff and patient support role long before COVID. So we'll come on to that shortly. So thanks very much for the invitation. I think if we can get the presentation up, I will see if I can advance this from. Yeah, brilliant. Thank you. So we're going to talk about the UK experience by kind invitation, and at Derek and colleagues' request, just going to cover touch on capacity, past, present, and future. Just give you a portrayal of the system under stress as experienced at the front line, positives from the pandemic, of which there are some, and then we'll move on to the psychological impact and actually how it relates to capacity and ratios and stretch as well. And that's very much Julie's specialty, and she's led on a lot of this work for us, so I'll hand over to her at that stage. Just to orient you to the UK landscape, which is fairly complex. Sorry, I'm just going to change my screen on here. I won't bore you with too many acronyms and initials, but there are. Okay, so I'm seeing a map of the UK. There should be some initials coming up when I press here. I can't see them on my screen, so it's just there we are. So there's the NHS in the 4 nations. Including in Northern Ireland, you can see there. Public Health England was obviously part and parcel of the COVID response, but within the NHS had direct bearing in this case on things like PPE provision and guidelines. Sorry, I've got a little bit of a lag here, so I'll just talk. So Health Education England, on the England side, was dealing with the trainees and redeployment. The NIHR was a research arm. ICNARC is our national database, and actually we had a lot of direct input from the Cabinet Office, who are getting involved in things like ventilator provision and actually many other aspects of COVID management. Alongside that, the professional bodies, the Intensive Care Society, which is ours, the AAGBI, which functions in Ireland as well, and the RCOA and faculty. So these are the anaesthesia and intensive care medical professional bodies. And along with that, the UK Critical Care Nursing Alliance, and apologies in our absence to Nicky, as the BACCN, which is part of that, has disappeared somewhat at the bottom of the slide there. So lots of things going on, and I'm sure mirrored by the situation in Ireland as well. And a combined government, NHS and professional body effort to work on everything from guidelines through to staffing, through to supplies provision, and a response. I'm sounding a little bit blank, it's because I can't see whether all these things are coming up. So in retrospect, these slides are a bit complex for this format. So don't worry, that was probably the most complex one. What I'm looking at now is critical care bed numbers in the UK. Delivery starting from 2009 onwards. So this is answering the question, has there been a massive surge in provision after the last pandemic, H1N1, to which the short answer is no. What there has been actually was a significant build-up of ECMO provision, with the advanced respiratory centres going from a single centre at Glenfield through to 5, covering the whole UK. And that proved to be a massive asset during COVID. But there wasn't really a significant overall critical care bed provision change. The position of the UK, I think, is very similar to Ireland in where we sit in Europe. We're not at the same order of magnitude as Germany. Internationally, equally, North America clearly is ahead in terms of numbers. So I think we both sort of sit in the middle. And the other thing to note, these are all data all from King's Fund report, but the other interesting finding is just about disparity, I guess. So unsurprisingly, critical care provision in teaching centres is higher, not only because they're bigger, but proportionally they have more critical care beds per hospital bed. And this really touches on, given that where they tend to sit, which is in urban areas, they do have deprived populations, but it means that relative provision in some of the more isolated areas could be disproportionately underserved by critical care. And that's obviously become significant when you have acute influxes. Early stage issues in the response to COVID. I mean, we've all lived through the same pandemic together, so I won't sort of bore you with the obvious. But physical expansion, changes in staffing, early priorities were around the sort of harmonisation provision of PPE. And obviously equipment with a lot of focus on ventilators and other things. And as we may have found elsewhere, in fact, the thing we nearly ran out of was actually hemofiltration fluid and consumables for all the emphasis on ventilation. Again, this will be familiar to everyone. Lots of scrubbling around in the early phase of the pandemic. Old ventilators there with chipped handles being brought out of the attic. Lots of plywood, so much plywood, polythene sheeting. Lots of physical capacity changes, including power and oxygen provision. I'll see if this works actually. So one thing that you may not have come across in the Republic is, so this is the famous London Nightingale, which is a large conference centre which was repurposed for theoretically up to 4,000 beds. And I just like showing this video because it just shows the physical scale of the thing. In the event, as you'll be familiar with, only 30 to 40 beds were installed. It was actually useful, particularly for people like me in London on that basis. But to give a reminder of the scale of potential escalation that was being talked about, and obviously what this doesn't cover is the staffing involved in that, and we'll come on to that. Early on, the directive came down that staffing ratios of a change of critical care nursing from 1 to 1 to 1 to 6 would be considered acceptable in terms of regulatory and governance. And that number was derived by working out theoretical maximum numbers required and ventilatable in a critical care setting based on the sort of China experience, and then essentially dividing by the number of people that were present. And this is in terms of fully trained intensive care nursing, backed up by redeployments, as we'll all be familiar with intensive care consultant ratios going from 1 to 12 to anything up to 1 to 30. So these were estimates in advance and a message that be prepared to do this. And we'll talk about how that sort of panned out. I'll put this slide up. This is a picture of my unit shortly after we moved into an infectious disease ward with one-to-one rooms, and we sort of migrated the ICU into there for about 10 minutes before we scuttled out again when we realised it wasn't working. But this picture to us now looks a bit shocking. Everyone's standing there without masks on. But as a reminder of how much things have changed in the last 2 years, this was at a time when there were a relatively few number of patients in the community. Those that did come in went straight to infectious disease and ICU. And a bit like SARS-1, this is a kind of a small number of cases in a small area, and people wandering around the corridors around the hospital looking completely normal, not even face masks on. So this wasn't because we were behind the times, it was just a reminder of the scale of psychological changes, if you were. On that note, I'm just going to take the liberty of playing two things. This was David Nott, who's wrote the book called War Surgeon. He goes out with Médecins Sans Frontières to various areas. He's also a vascular surgeon, general surgeon, operated on Tony Blair's appendix in his spare time. But he kindly did a message for us just about the shift in mindset required when you sort of parachute into these places. And this was very early on. This is February or March 2020. And I'll see if this works and plays. I'll ask the tech team to message me on the chat box if it's not playing. No, I'm seeing shaking heads. That's fine. I'll move on, and I'll skip the next one as well, which was a war reporter from ITV who kindly did the same thing for us. But basically what they were saying was, look, be prepared to put a different head on. You've got to shift in mindset from everything you're used to a completely different world, which now may seem like motherhood and apple pie, but I think it is part of the sort of trauma of this all, which Julie will come on to. It's just a shift in expectations of actually for your entire career has been spent doing one-to-one nursing and letting somebody know when you're going on break so that the patient's never uncovered, and suddenly you may be asked to do 1 to 4, 1 to 6. As a consultant, you may be making triage, rapid decisions rather than doing ward rounds and so on. So it's that shift in expectations. In terms of absolute numbers, this is a time course in the UK, anything up to 3,000 COVID ICU patients at one time. This is given an ICU bed base of around 4,000 in the UK. So although those total numbers may sound as if we're well within margins, I'd remind you that these is unevenly distributed. So in the hot centres, we were well over capacity or pre-existing capacity, and then there were other areas such as the southwest of England in the first surge where there actually was very little going on, but they were subject to all the same restrictions and stoppage of elective surgery and so on, and that sort of evened out later. Just to show you what it's like in one centre, this is my unit. So we went from a 20-bed unit to a peak of 55 patients. And the red there is the COVID patients sort of overwhelming everything. The blue's disappearing completely for a while as patients stopped coming into hospital with other conditions, in some cases delaying things on a voluntary basis, in other cases elective surgery stopping. And from an incoming numbers point of view, we're looking at numbers here about, I think, up to 15 admissions to ICU in a day. And we were in a place where we could rapidly move within a network to shipping people out to other neighbouring hospitals and to the Excel. And those numbers were themselves quite hard to manage, actually. 5 to 6 transfers out a day, trying to identify them from among the 55 patients in the unit. So lots of sort of communication, operational flow issues, as well as the challenges of care at the bedside. This is just an example, a map of our network showing lots of flows between hospitals, lots of flows outward. So where this touches on capacity is basically we realised very early on we couldn't just expand indefinitely in situ and would have to move people between sites. And that, together with some of the psychological data that was coming through early on, led to a change in expectation from NHS England, particularly around not expecting individual sites to go to 1:6 nursing ratios, but rather accepting lower ratios of 1:4, and accepting that if there are the total number of beds in the country is above the number of COVID cases, then a lot more movement is required to decompress. So this idea of mutual aid decompression really took hold during Surge 1, but became part of the model during Surge 2, by which I mean the autumn and winter of 2020. Other trends during the surges, and again, this won't be unfamiliar to anybody. So, what started as a novel disease became better understood. Treatment strategies changed, including increasing use of NIV and obviously all the medical treatments. Supplies resilience went from a stage where we weren't sure about degree of oxygen provision, including delivery to hospitals and whether there'd be enough tankers, through to PPE, through to drugs. All those things evolved as things went on. Pressure on infrastructure, lots learned about oxygen piping that people never expected to have to relearn after basic physiology exams, in our case. Evolving staffing models and the impact on staff, which again is a recurring theme we'll come back to. I'll sort of defer to Julie on this, but I think just in terms of general headers, as a sort of doctor, as a consultant, we tend to focus on difficult decisions, but actually, obviously, that's only a part of it. It was a new disease. There was significant fear attached to it early on, and again, we've all lived through the same pandemic, so I won't drill into those, but bearing in mind people were worried very early on about taking the disease home to their families, as well as for themselves. That emotional transition, I'm sorry those videos didn't play, but it's we felt this. So the first time we were admitting 4 people within the space of an hour and looking at each other thinking, this is just a different world. I had a consultant break down in tears and rush off, very understandably. We all went through some period of transition, and it may have been the people coming on to shift for the first time in a few days, seeing a completely transformed unit. Lots of just the fact the world has changed is quite a difficult thing to get your head around initially. Difficult working conditions, obviously PPE, difficult communication with each other, with patients, with families, disconnection from patient families, so that nurses, particularly who are used to having relatives by the bedside, now lose that contact. All the sort of family communication was devolved to the junior doctors over iPads and things. And the cognitive dissonance of working in a different world where you're expected to be looking after 4 patients rather than 1 and supervising other people, and just the sort of responsibility aspect of that. Positives we were asked just mention on these, and I think a lot of it, as we've all seen, a lot of innovation went on. Everything from using Teams and video chats to so an example of that, just to give a concrete one, is of our daily catch-ups with the acute respiratory unit, so that we evolved a kind of telemedicine low-tech through phones system, which actually we'd struggled to deliver in the 5 years preceding, despite lots of conversations about how can we work seamlessly. In my case, I work in a 3-hospital trust. We never managed to get video link working properly between all the sites, and then in the course of COVID, we came up with that very quickly because we had to. Collegiate working, so lots of challenges with redeployment, but actually, and this may have varied a lot between sites and organisations, but we benefited from a big influx of people coming to help. So although very stressful for everybody involved, lots of positives came out of that as well. And I think my screen's disappeared. I think the two main other bullet points were just around the increasing profile of critical care, both strategically, everything from research funding prioritization through to greater awareness among hospitals that ICU isn't just the back end to be used in extremis, but is core to all the patient pathways. And we obviously all knew that, including everyone in this audience. But I think it brought that to the fore. And for the public as well, I mean, this is it was more than obviously not just a PR exercise for ICUs, but it's about increasing understanding of what critical care involves and how crucial it is, and opportunities to bring that out. And a big positive has been research, not in the sense of just lots of sick people to research on, but actually, again, that profile aspect. And I think importantly for clinical staff, I think it really brought in the centrality of putting research into clinical practice. So the fact that every patient coming in should have access to trials in every setting, not just the academic places. And I think that has been a lasting effect. I think I've lost sight of I'm seeing a big picture of me on screen now, which may be what you're seeing. So condolences to you. There we are. We're back. I won't go into all the details of recovery RS, and remap cap and so on, but obviously this was a first real major deployment of remap cap and its sort of platform adaptive methodology. And there were people who are better qualified to talk about that than me. And I'm going to just finish on talking about capacity. So I think this is obviously about the future of critical care in Ireland. I would love to come to you and say that Julie and I and others are basking in a rosy UK future where lots of money is being thrown at critical care for the next pandemic. Unfortunately, this isn't the case. The capacity improvements, such as they are really focusing on things like level 1 care in UK terminology. So enhanced care, the sort of slightly ward plus acute respiratory unit, post-operative surgical unit model. Where that may impact on full-blown intensive care is in decompressing some of the demand there in terms of significant numbers of patients staying after operations. But bearing in mind, those patients only stay for 1 or 2 bed days normally, so the decompression may be relatively limited. What it may do, though, is give a pool of intermediate grade physical capacity and staff that can be upgraded to critical care again when needed. I think that's the argument for it. And then the transfer systems that I mentioned are sort of central to future kind of mutual aid decompression models. I think from a clinical perspective, I'm not here to sort of speak for NHS England. We do sort of work collaboratively with them, but so I'm trying to sort of convey the model that's come out. I think everybody involved, including all the clinical representatives operating at those levels, would have preferred to have seen a big influx of cash saying, okay, let's just make the system resilient for future surges, as well as the fact the current one isn't going away anytime soon. But that hasn't been secured, shall we say. I think any expansion and new builds, and there are some going on in the UK, it's going to be a case of building what's been learnt from COVID, using that as part of individual business case and saying, look, we need to allow for cohorting. We need to, how are we going to continue supplying elective surgery in future while we build this new unit? Let's build it with pandemics and infection control in mind. And there may be individual impacts in terms of upgrading the capacity at local sites, but there hasn't been a big surge of, okay, let's get our UK critical care capacity up to 8,000 or whatever. And I'd have to say that was the case, but unfortunately not. So that's the capacity angle. But throughout all of this, the impact of stretch and dealing with capacity by using the existing workforce differently has obviously had psychological impact, and that's a lot of what this is about. So I'll now hand over to Julie. Thank you.
Thank you. Are the slides going to come up? Lovely. Fabulous. Are you able to move them on, or do I need to move them on now? I'll do the clicker. Okay, I'm not quite used to this clicking on one screen and doing it on the other, but I'll try my very best to learn this new skill, as we all have during this time. So yeah, I'm pressing the green button. It's just on a different screen to my Zoom. Which is very bizarre. Okay, there we go. So I'm a jobbing ICU psychologist. I have worked in South Wales, in Cardiff, for the last 7 years. And last year I started a 2-day-a-week secondment with the Intensive Care Society as their wellbeing director. So I guess from a wellbeing point of view, what I would say is everyone focused on mental health rather than wellbeing. well-being I consider more the experience of work, and everyone measured how badly their mental health was affected. Most famously is Neil Greenberg's group. They're the most famous because they're the ones who press released their pilot data, and they basically said that 40% of our staff have PTSD. Interestingly, in the same time frame, someone in Dublin said something different, and I thought that was worth sharing with you guys. So French Carol and their team actually said that PTSD was more like 14%, and actually Greenberg's later data now is revealing it's something like that. And actually, that's what we were looking at. Gillian Colville's group was saying that across adult and pediatric ICU pre-pandemic, i.e., this was already a tricky place to work and already a place where lots of trauma was experienced. There was more trauma in a pandemic, certainly, but it's a bit more complicated than just PTSD, which is a sort of easy label to add to something more complicated. The other one that we used to think about quite a lot pre-pandemic, but people don't seem to talk about as much. But this is a study that's across the whole of the world, 77 countries. Walster's group looked at 2,700 people and found that half of them were burnt out in healthcare, which is really, really fascinating to see that, actually burnout is more of the picture. Obviously, from a PTSD point of view, we think about kind of the intrusive memories of what you've been through. When we think about burnout, we think about feeling emotionally exhausted, disconnected, and feeling like you've got nothing left to give. So, two slightly different experiences there. But realistically, what do people say? Because mental health is just far too narrow. One of the most useful phrases has been the label of moral distress, which in short is we see the gap and we fill it, and that is distressing, if not harming. Um, but also, in the stress of it all, we've had issues with each other. Our tolerance is low, our relationships have been affected, our mood and morale has been affected, and staff have felt a split, especially senior to junior, nursing to doctors and AHPs. There has been some disintegration, and there has in society as well, to be perfectly honest. Um, it's great that there has been energy and innovation, but that has fluctuated. And there has been investment, but sometimes that education doesn't necessarily catch up. And people keep going because they're NHS and they feel that they have to. So it's not just the people who are off sick from work and absenteeism, but the very harmful idea of presenteeism, which is where people stay in work when they're unwell. However, I have to say, with this wave and with seeing that Omicron hasn't quite hit us in the way that we had expected, I can see images of us starting to emerge, and there are some glimmers of hope. I guess just a couple of one-liners from my staff, and it's worth saying ICU went into surge. I just did my data, and my 2021 staff wellbeing referrals were 179% higher than they were in 2019. So I went into surge too. So I could tell you most of these quotes also go for me as well. But there's lots of kind of talk. Obviously, we talk about rest, self-care, but every day I come in and I give 400%. I go home and my rest can only restore the 100%. So I'm in deficit before I come to work. And then just to jump to the bottom, more worryingly, the number of people I've heard that have lost the love for this job. So we've seen a lot of turnover. We've seen a lot of complicated psychological reactions to all of the things that Ganesh outlined in terms of the job changed, and it changed for a sustained period of time. So we had a lot of investment, a lot of fundraising within the Intensive Care Society, and they employed me 2 days a week. And we've taken a whole program approach to our project strategy, starting at the top and working our way down. First things first, we wanted to provide as much one-to-one help as we possibly could. So we got funds for that and pulled together a group of psychologists to do that. We realized that not everyone wanted one-to-one help, so we created created lots of different resources and spaces to reflect and learn, education, podcasts, webinars, written resources. And then our longer work has been saying, actually, this was already tough work and we've just made it tougher. And we've poured water into the cracks of the NHS. So, how do we take a step back when it comes to intensive care and think about what good looks like and the core conditions to thrive at work? So, beyond well-being. So, we've done a lot around teamwork, peer support, and pulling together guidance for units. And you can get all of that on our website. So here's a screenshot of it, and it's just one link. So it's ics.ac.uk/wellbeing. What we know is over 80,000 people have utilised our resources in different ways, some directly through the website, some through YouTube and watching our webinars, some through the peer support programme and the psychological help and one-to-one. So it's been an extensive reach. We know it's a lot of our resources have been translated into other languages. So Norway recently, Argentina at the start of the pandemic, working with people in the US as well. Some of my work has led to the extension of psychology in ICU. So that's gone up by at least another 20% through my work, which is just incredible. So the UK really does lead in terms of ICU psychology now. So plenty to be proud of there, and also knowing that this resource has been available beyond ICU because we've had so much in common. And then just a last kind of plug really is we've been kind of as Ganesh is saying, we've been connecting. There's been lots of positives of our well-being and the way in which we've worked together. The light at the end of the tunnel and the sort of silver lining to the cloud of all this doom and gloom is despite the fact that we have gone through a lot. We've gone through a lot together and we've pulled together and we're in those stages of recovery. So what better than to come and have a knees up in Belfast and celebrate. The date went, but I can tell you it's the last week in June, first week in July. Submissions are now open and you can also register to come. I'll be presenting a bit, so if you want to hear a bit more from me, I'll be there, and I'll also be in the pub afterwards. So that's enough from me.
Many thanks to Ganesh and to Julie for that really good talk with regards to their experience of COVID and especially around the importance of the clinical psychology support within critical care, something that we really need to start driving within the Irish critical care community. Just finally as well to plug as one of the conferences that was up there, which is the joint British Association and Irish Association of Critical Care Nursing conference, which is happening in Belfast in October. And for our last speaker, our penultimate speaker, I'm delighted that we're being joined by Dr. Philip Gillen. Dr. Gillen is the clinical lead for the Critical Care Network in Northern Ireland and also the Northern Irish Specialist Transport and Retrieval Services. And Philip is going to talk to us on the Northern Irish experience of critical care over the last 2 years and plans for the future. Thanks, Dr. Gillen.
Thanks. Thank you, Derek, and thank you to everyone for the National Clinical Programme for Critical Care for giving me the opportunity to speak. I'm joining you from work in Belfast. Claudia and the AV team are in control of my slides. So hopefully they will be coming on stream anytime soon. So yes, I'm the clinical lead both for our clinical network here in Northern Ireland and for NISTAR, which is our adult transfer service. So during this talk, I hope to give you some context around the Northern Ireland experience. Clearly, there's a lot of shared experience and issues which have been sort of universal across all Western healthcare services. I just highlight some of the differences that we've experienced within Northern Ireland, the impact of the pandemic, utilization of the sort of Nightingale facility, which one of the few places within certainly within the UK in which we actually had a large number of ICU patients, ventilated patients. The effects that had on us, and also in our plans as they changed into a sort of post-Nightingale type plan for the subsequent surges that came. Briefly talk on some of the lessons that we've identified and some of the sort of the positive learning that we've had as well, and on the future plans that this has had for Northern Ireland. So, we've seen these before. I mean, so with regard to the OECD sort of countries in ICU sort of bed provision, if we click down through the next few slides, please, Claudia. So England, just I know I listened to Ganesh on before, so a lot of these things have been sort of discussed. But if we were to try and find where Northern Ireland is in terms of provision of ICU sort of beds per head of population, they are broken down into essentially the 2 million population of Northern Ireland into 9 sort of acute trusts, 5 trusts with 9 sort of acute hospitals within them. The ICU provision within them has been grown organically over the years, and isn't really sort of dependent on the population basis that they serve. If we were to look at these data for ICU bed sort of provision, we are approximately 3.7, so just below New Zealand, just above sort of Mexico. So we knew pre-pandemic that our numbers were extremely low with regard to sort of our neighbours. Some of the physical infrastructure was a significant burden for us as well, or problem for us. This is the Mater Hospital in Belfast, which is a district general hospital, but it's the respiratory centre within Belfast, and serves a very wide sort of population. Unfortunately, due to staff shortages, which were pre-pandemic, the intensive care unit here had to be closed and was moved to another hospital within the trust. So we had essentially the respiratory hospital taking an influx of the vast majority of the patients with COVID, with no ICU facilities at the other end, which proved to be a significant burden on us. If you look at a map of Belfast, so the Mater Hospital is up on the top there. The subsequent Nightingale facility, which was opened in April of 2020, was in the City Hospital, which is mainly a sort of elective facility. The main tertiary major trauma centre and the largest hospital is the Royal Victoria Hospital, from which I speak, and it was again a distance away from all of them. So what that meant was that we started off with an imperfect imbalance between where the resources were, and subsequently they were put to the test as the numbers significantly increased. This slide represents the level of deprivation in the Belfast sort of area, and we know that COVID particularly affects more people from lower socioeconomic sort of classes and areas of sort of deprivation. So this is unfortunately just the catchment area for the Mater Hospital and the respiratory wards. And also we know from public health data that these are the areas that have the lowest uptake of vaccination, and the highest percentage of underlying sort of health inequalities. So a significant sort of burden for the network, both in the terms of the numbers and the degree of hypoxic sort of respiratory failure that we had to contend with hospitals that had limited or no ICU capacity within the network. These are the data for the deprivation indices for the rest of Northern Ireland. The major population areas contain the 10 worst postcodes with regard to sort of deprivation throughout Northern Ireland. So in these maps, the centres of population are red, which is most deprived, surrounded by areas of lower levels of deprivation. But unfortunately, our hospitals are not built around these areas and are generally placed from historical geopolitical reasons within the various centres in which we find them. As the pandemic surged, with its multiple surges, we saw this sort of recurring pattern. And so the centres of population around Belfast, and then it spread out through the countryside with significant some burdens in centres of population more than others. This proved to be a significant problem with regard to sort of the logistics of transferring these patients in and around Northern Ireland, which I'll allude to in a second, and actually getting them into the Nightingale facility as well. This is the Nightingale facility that we had. This is the Belfast City Hospital tower block. The man on the left is Robin Swan, who's our health minister. So with great fanfare, this was opened in April of 2020. Just over a year, it was, as far as we can tell, the longest sort of Nightingale facility that was used within Europe. It was built over to accommodate up to 250 ventilated cases. Now, we never went up above, the high tide mark was 45, but we had to make sort of plans, both from a nursing point of view, logistics, and from a resource allocation as to whether or not we would ever get up to sort of the higher multiple hundreds of patients that would require ventilation. It soon became apparent that the rate determining step and the resource limiting step was the lack of sort of both space and skilled ICU nurses. So this is a picture before the Nightingale went live. These are essentially hospital bays that we've shelled out and put ICU equipment in. And then when we were running the facility with 3 intensive care patients in each of these sides, so 6 in each bay. So it became very sort of claustrophobic. There were issues around sort of communication amongst staff and whatever, and it proved to be quite a challenging environment in which to work. This is the brand spanking new hospital that I'm calling you from now, which is has a large ICU facility, but is unfortunately the tertiary centre for Northern Ireland. So it takes all the tertiary referrals with regard to the District General beds that we had for COVID. They're actually sort of quite limited. So we had a difficult environment in which to nurse and care for our COVID patients throughout the subsequent sort of Nightingale use. So some of the positives that came out of the pandemic, so and it is useful to highlight the impact that research and uniformity of care throughout the patients in a pandemic. So we were very pleased to look at immunomodulatory drugs and their effects through the ICNARC-driven and REMAP-CAP studies to enable us to improve our outcomes and very rapidly disseminate this information to ICU and non-ICU sort of clinicians, clinical staff, nursing staff, or whatever, so that everyone was aware of the current research on what was initially obviously a novel pathology, which we then we could tackle and improve our outcomes significantly over the course of the pandemic surges. If you look down in the bottom left, these are the infographics from the Department of Health in Northern Ireland, and it shows the surges quite nicely. You'll see that the bottom left, the red graph, shows the high tide of our patient numbers as 71 COVID patients, the ventilated level 3 patients in Northern Ireland. This was the second wave peak, and it corresponded to, as I say, the high tide mark of 44 patients being ventilated in the Nightingale facility. Then it went down very sharply until April time, when we actually closed the Nightingale facility. And then we had a subsequent surge, which has stayed the same and has been plateaued since for a number of months. Is only very slowly coming down now. So we knew from our evidence that the Nightingale facility was useful during the first and second surge. We weren't going to be able to use it again. We had significant issues getting staff to come, principally ICU nurses, which are clearly the key components to any ICU care delivery. Getting them to come from other facilities to work in the Nightingale facility was a real challenge. We relied on the Belfast Trust of the locals or ICU nursing population to do both the tertiary unit work in the Royal Victoria Hospital, and then also work in the Nightingale facility. And this led to a significant, I've written down decimation of the nursing staff numbers, so that's an understatement. So we were at 50% of our nursing strength here, and we're only very slowly sort of building that up now. So we knew that and if we were to have another significant surge, we had no real option to have another go at doing a Nightingale facility. So what would we do? So it came then to sort of planning about how we would work in a post Nightingale environment. So we thought it'd be better to surge in position across the acute hospitals that they had. We knew that that this would have a significant impact on all the hospitals, staffing, morale, and we've already heard from the issues with regard to sort of psychological impact on all of us, including the nursing staff. But as I say, the nursing vacancies were low beforehand, or rather high beforehand, and they now are very high. We're only slowly fixing them now. These are the surge plans as they come up on screen for our as we surge across each of the units, and we went round them all and determined how many was their maximum sort of capacity. And in turn, we developed an operational hub network whereby we could increase the number of beds available throughout our relatively small network. On the right-hand side, you can look, we referred to the sort of pandemic crit-con sort of levels. So this was for post-Nightingale sort of facilities and trying to increase the number of ICU beds in each of the hospitals in each of the, across the network. As the surge levels increase, we then have a maximum number of beds that we could actually accommodate, which we believe to be 119 down the bottom right. At surge level 4, you've got what is classed as limited emergency activity suspended. And the decision to escalate or de-escalate to crit-con pandemic level 4, which we use the UK's Intensive Care Society nomenclature here and their descriptions of those. So I'll just briefly show what they were. We were running at about 105 beds and coming close to this. We were looking at discussions with our Department of Health and Chief Medical Officer with regard to using triage and reverse triage to limit the number of COVID patients that were ventilated prior to ICU admission. These are the ICS crit-con pandemic levels. On the next slide is level 4, which is obviously code red and triage risk. So a significant risk of us, we came within about sort of 10 beds of having to invoke a change in our focus to focus on minimizing sort of loss of life. And we had developed decision-making aids and tools based along physiological variables and the clinical frailty score to talk about de-escalation or reverse triage of patients in ICU. So this became, we were close to having to invoke this. So we obviously had a north-south collaboration and met Michael and Derek on that. So we have a memorandum of understanding between the both sides of the Northern Ireland border about if we were overwhelmed to move patients from one border to the next.
Apologies to Dr. Gillen, the link keeps on dropping in and out, but really thank you very much, Dr. Gillen, for your presentation with regards to your Northern Irish experience, and we look forward to continuing our North-South collaboration as we go on through the future. And we're coming to the end of our day, and I'd like to introduce the Chief Clinical Officer in the Health Service Executive, Dr. Colm Henry, to give the closing address for the conference. Many thanks to you all.
Derek, thank you for this kind invitation to close the conference. It's particularly good timing when we consider that we appear to be emerging from the latest crisis, latest challenge that COVID-19 is thrown at us in the form of the Omicron variant, and thankfully we're able to look perhaps to a brighter few weeks or months ahead, notwithstanding the many uncertainties that could lie ahead with COVID-19, but certainly a brighter day than any of us would have expected by the time you organise this conference. And it allows me perhaps at this pause in our pandemic to thank and acknowledge the critical community for their outstanding clinical leadership in what is the most frontline settings throughout this pandemic. And it wasn't just leadership in terms of the clinical leadership within their own domain, but also in facing out to the public and reinforcing what a threat COVID-19 was to the country, and how it was a condition much easier to prevent than to treat. And there are many of your members who played their part in bringing the debate beyond critical care, but out to the public to ask them to do their bit. And I think there were some seminal moments we all are aware of that members of your community played in bringing us through what has been a very difficult 2 years. I'd like to particularly acknowledge Derek, yourself, and Michael and Una. When we look back at the model of care that was developed as far back as 2014, Michael reminded me recently, it's hard to believe it's now 8 years ago, the manpower work you yourself have carried out in the critical care nurse career pathway, but above all for your collective patience, when for so many years we applied for funding, applied for beds corresponding to the model of care, and had so little success. And thankfully now, again, we see that we're at last securing the government commitment and the joint HSE government plan on the expansion of the critical care capacity in terms of beds and training and manpower to a level that we need in this country. Just on your own, the model of care has served us well in terms of reconfiguration, in terms of wider healthcare arguments. It's a hub and spoke model, and it looks towards a type of care that we've used in trauma, in cancer, where expert specialist care is condensed in a number of centres in this hub and spoke model, while Model 3 hospitals and others have their part in delivering local care. But it's entirely in line with other national strategies, in particular, as I said, trauma and cancer. Your own work, Derek, the training in preparation for the funding, which we all hope would eventually come, has been formidable. 532 nurses have completed the National Foundation Education module, a further 90 commencing in February. The Mater, Vincent's and James is running their own independent accredited courses, and annually 100 to 150 nurses, I understand, graduating in this postgraduate diploma in critical care, and additional posts in critical care, nurse education and ANPs as well. The contribution of the wider community in intensive care has been huge during the successive surges we faced. The flexibility they've shown, the responsiveness, and epitomise not just your collective and individual expertise, but your professionalism too, in responding in a calm and measured way when the rest of us didn't feel either calm or measured as we faced into the great unknown that each successive surge in cases brought us. We entered the pandemic with a widely acknowledged under-resourced critical care capacity of 255. We have expanded that. We need to reach that 321 and 329 by the end of 2022. And of course, we have the wider plan, the phase 2 plan, designed by Michael and colleagues to go beyond that, the additional phase 2 beds in 5 centres. That has now thankfully reached the acceptance and commitment of government and ourselves to promote and progress as quickly as possible. I have to mention also that standards of care, which have been carried out again in the most difficult times. I want to acknowledge the work of Rory Dwyer and others in NOCA, where they tracked and measured the care and also supported us here in the HSE in providing a kind of a barometer of the degree of heat that the intensive care system was experiencing, not just within intensive care units, but outside intensive care units. As you know, we reached the highest peak in the January 21 of 215 patients with COVID in intensive care settings, a total of, at that time, 330 beds, representing a significant additional surge capacity, which was only achieved through a training of staff, through deployment of staff, to designation of additional areas outside intensive care units. At one time in last January, over 50% of all intensive care beds were occupied by patients who had COVID-19. And the outcomes as produced by the NOCA report are comparable to any similar nation. Mortality, as I understand it, overall of 28%, with some differential between the surges. But again, a huge acknowledgement to yourselves. And of course, we know that beyond that, there was work outside. David Menzies and the Critical Care Transport Programme, the work they carried out, especially during the surges to ensure we could maximise our use of beds. And of course, the care that was provided to people outside intensive care settings using the guidance of the critical care community and the collaboration with other physicians within the hospital. Also, would like to mention, if I could, the generosity of spirit demonstrated by your community through one of the most positive experiences I've had the past 2 years of the ICU for You cycle organised with Patrick Singh. And all of us had a hugely enjoyable experience, notwithstanding the fact that it was carried out at a time when we had to comply with public health measures. But nevertheless, it demonstrated that not just that the community of critical care was not just professional and expert, but also generous in deflecting the attention of the pandemic away from themselves and their own hard work, but towards patients, towards those who died, and towards the charities who benefited, up to €150,000 alone, Aware Northern Ireland and Breakthrough Cancer Research. So I'd just like to close, Derek and colleagues, by saying we owe it to all of you and all of your community that we progress now with this plan, the plan underwritten by Michael Power and the Critical Care Programme, underwritten by the community, to see this through and ensure that we're better equipped facing into any future pandemics or any future challenges healthcare will bring us throughout our working lives. And Míle buíochas as up for see here. You have when the history of any crisis is written, medical professions going back many years have always had a place, be it the history of Irish famine or pandemics or influenza outbreaks in 1918. And I'm sure that when the history of this pandemic is written, critical care will have pride of place where their response demonstrated that they exceeded even their own high standards. So, míle buíochas. Could I just say, Derek, I'm going to invite, as the last speaker, Eileen Whelan now to present flowers to Una Quill, who organised the whole meeting today.
Brilliant. Thank you very much, Dr. Henry. And I hope everybody else has a good weekend. Thank you.